I see. Well, with us in studio is the great Gerard Gibert. Good morning, Gerard. Thanks for being with us this morning.
Gee, I don't know about great. It's overtime, Gerard Gibert.
That's the truth. That's the truth. You staying here for the whole day?
Exactly. I will say this. There's one fringe benefit of doing the early show. Plenty of parking spaces.
Oh, that's the truth. I've had this experience twice, and I had it this morning where I am coming in, and I don't always do a great job of getting here at 5:30. Sometimes I'm coming in at 6:01, knowing exactly when the mic gets hot. But every now and again, there'll be somebody who's coming in super early for work, and you can tell it's pitch black. It's early morning. We broadcast from Jackson, and they see this old model pickup truck hauling in, trying to get to a space. And somebody's sitting there either holding their peace or thinking about running to that door because you worry somebody's coming for them. And anyhow, whoever that was, I hope you're listening. I hope you're having a great day this morning. But I could tell I started their morning with a start.
Yeah.
So.
Well, we're here, and the building's empty.
That's right. Well, thanks for being here. I'm used to talking to you in the studio. Normally, I'm sitting where you are, though,
right.
So this is a different experience.
Yeah, exactly. Appreciate you having me.
Absolutely. One thing we've talked about both on the air, and I was talking about this a little bit in the 6 o'clock hour, one thing I think you do a great job of, both on your show and just generally, is thinking about these political issues and really digging into the data that, as opposed to just saying, well, this is the conservative talking point and I'm going to repeat it. I think you do a great job of digging in deep and being able to analyze these sorts of things. And clearly the folks in the legislature feel the same way. I think you testified this week, right?
I
in front of the joint committee, is that right?
Yeah, joint public health and Medicaid committees, joint meeting, of course, both chambers, House and Senate. I would have to guess there was probably 35, 40. I may be off a little bit. But there's a lot of people, around the tables there put together in room 113, first floor of the Capitol. Honored that Representative Sam Creekmore, who, of course, is the chairman of the Public Health Committee in the House, contacted me a couple of weeks ago and asked me to come testify. And I think a lot of that, Lucian, was driven by this article that I wrote, that's published at SuperTalk.fm. I discussed it extensively on the program, and I know many of the members have read it. And I apologize in that it takes a while to get through it.
Well, it's not a simple question.
It's not, and that's the fundamental issue. As you know, perhaps the only thing that's more complex than health care from a policy perspective is tax policy. And usually when you start talking about that, you really get folks nodding off. But it's complex and it's deep and wide. And the crazy thing about health care, especially with respect to the Affordable Care Act, which is kind of what governs our health care in the United States, is that it's most of the code that emanated from it is in the IRS. It's an IRS law.
It's a tax.
You think about it. It's a series of debits and credits, and I actually explained that in the article. And if you think about the issue of health care in the state of Mississippi, what I tried to convey to the group is you got health, and then you got health care.
That's a good point.
And we have issues with both. We have a very unhealthy population, the most unhealthy, unfortunately, in the country by any statistics from any reputable sources. And then there's the issue of health care, and, of course, that is the provision of care and treatment and drugs and procedures and therapies, et cetera, the entire gambit from other humans. It's their work product.
Right.
It's their job. It's how they get paid. It's how they live. It's how they get compensated. So you've got to, I think, distinguish between the two. One of the issues we have in the state of Mississippi is just a high amount of uncompensated care.
And for folks who don't know, you explain a little bit what uncompensated care means.
Yeah, sure. So the typical patient, let's say, that is admitted to the emergency room. This is a common scenario. They're sick. They don't have insurance. Okay, they're sick, and so they don't have the option of going to see a primary care doctor in general. I got sniffles, is something simple like that, and it could be something extremely urgent and emergent and critical, such as a heart attack or a stroke or something you got to take care of right now. Well, when you show up in the ER, if that hospital participates in Medicare and Medicaid, which I don't know any that don't, right, honestly, they are compelled by law to treat that patient, stabilize the patient. And that is through the emergency medical assistance Emergency Medical Assistance Treatment and Labor Act, I think I got the acronym right, but it's EMTALA is what it's commonly known as, passed in 1986, signed into law by President Reagan. It basically says you got to stabilize anyone that shows up in your ER, even if they can't pay.
Okay. And it's just on you to, you got to eat the cost.
Yeah. So nobody shows up at the hospital that's sick in the ER, I don't think has ever been asked the question. Let's say you're showing up with a heart attack or a stroke. You got to get sent immediately into some surgical care, for example, to address that issue. It could be other treatments as well. But the bottom line is, I'm not aware that they ever stop and say, "Hey, can you pay?"
Right.
I don't think they do that.
I wouldn't think so. I think they'd take care of you.
They'd be hauled off into court probably,
right.
and the place would shut down ultimately. So that's uncompensated care. That is significant in the state of Mississippi. It's significant in the country. It's particularly significant because we have a high number of uninsured in our population. Now, the proponents of Medicaid expansion would say that's because we haven't expanded Medicaid, and many of these uninsured simply cannot afford insurance, and therefore they don't have it. The vast majority of people obtain their insurance through their employer, group coverage. Right. I think it's 85% of the total covered by the commercial market comes to their employer. Those that do not have access to employer-provided coverage, many small businesses simply don't offer it, and they're not compelled to by law.
Once they're under a certain size,
50,
is it 50? 50.
And so the federal government generally considers a small business, a small entity, to be fewer than 50. Greater than 50, they have to. And if they don't, by the way, they have to pay a penalty to the federal government.
Once they're over 50.
And they're not providing insurance.
Okay.
And if they provide insurance and it's deemed, according to the law, unaffordable, which is now calculated, it recently changed, I believe it's 9.1%, if I'm not mistaken, of their household income, then they have the right, does the employee, to go obtain subsidized coverage in the Affordable Care Act exchanges. And if that happens, if that's triggered because it's not affordable, the employer has to pay a penalty.
Okay.
Now, one question I've asked that nobody can answer is, how many such situations do we have? How many employers are paying penalties? What's that amount? How many employers more than 50 don't offer group coverage? How many under 50 don't offer group coverage? And to try to get an idea of exactly what this population is of uninsured.
Well, you and I have talked about this off the air, and you've made this point, but I think it's spot on. We're talking about making what is literally a billions of dollar decision
every year.
And it doesn't feel like we've got great data on which to make the decision right now.
We've got a lot of estimates, and they're from credible sources. So if you look, for example, at the presentation provided by the Hilltop Institute to the House Medicaid Committee on Tuesday. Well, that of course assesses all that information and provides that in a financial format. Here's the number we think are going to sign up, and that kind of scales. And they show a 6-year projection on that. And then the Mississippi Hospital Association presented their figures the next day, right after I spoke to this joint hearing. And there are a few discrepancies, and that's, I think, causes consternation for folks that why are they different? It's because it's not perfect, and you're trying to obtain lots of data, and you're trying to estimate essentially human nature. We don't know. These are the numbers that could show up, could be more, could be less. I guess from an economic perspective, one thing to keep in mind is that from a Medicaid funding model perspective, traditional Medicaid is funded by, of course, the federal government and the states, and so is Medicaid expansion. But the FMAP, the federal match on traditional Medicaid, is based on the per capita income of the state. We have the lowest.
So we've got the highest federal
it's
match.
About 77, 78%. The Fed takes care of. The state is responsible for the other 23%. And we're talking about in roughly a $7 billion program.
Wow.
Medicaid total cost is more than the general fund.
Well, we're coming up against a break. If you want to be part of the conversation after the break, hit us up at 601-879-4395 on the C Spire text line. We'll have more with Gerard Gibert coming to EIC. But we're talking a little bit about the possibility of Medicaid expansion. And, just to make it clear for folks who don't spend a lot of time thinking about this, Medicare is a separate program run by the federal government, different thing, and with some possible exceptions, it's for people who are older. It's essentially health care for people who are retired.
Over 65.
Over
generally.
65.
Yeah. And you pay into that every month in your payroll tax deductions. You see that. It's called hospital insurance, HI. It's part of FICA, and you see a Social Security component and a Medicare component. And then you pay in that as long as you're working, and then you get to a point where you retire and you sign up for Medicare, and Medicare then is the insurance you have, just like standard commercial insurance.
Right.
By the way,
completely separate from
completely
this.
separate. Has nothing to do with Medicare. So think about Medicaid being for low-income people, whereas Medicare is for retired people.
Right. So who is currently eligible? You talk a little bit about the population right now who gets Medicaid in Mississippi.
Yeah, traditional Medicaid, which was enacted into law in 1965. It covers the blind, disabled, low-income, elderly, pregnant women, and children. There's also an associated program called the CHIP program that went into place 20-something years ago, and that also is designated for children. And by the way, children comprise the largest number across the country and in Mississippi that are in Medicaid.
Okay.
A child could qualify for Medicaid in a household where the parent or parents don't.
That's an interesting point.
That's really what Medicaid expansion is designed.
So the population that we talk about where we would be expanding it, what does that population look like? So
all Medicaid benefits, just like all federal assistance programs, the eligibility is based on some income test. Usually it's household income. That's just all the income being earned in an address, literally, the household. That's the test. That can be sometimes very difficult to ascertain, as you can imagine. But the eligibility test determines whether or not you're eligible, I should say, for traditional Medicaid. All right, what we're talking about with expansion are working able-bodied. They don't necessarily have to work, but they have to be able-bodied. In other words, they don't qualify because they're blind and disabled. So sometimes they say able-bodied, sometimes they say non-disabled.
Okay.
So the able-bodied are in the same population, though, with a household income of less than 138% of the federal poverty level. The federal poverty level presently for a household of one is $15,000, and it is based on the number in the household. It scales.
So you'd be for a single person that means somewhere around $18,000 a year you'd be making.
20. Yeah,
okay.
138% is about almost $21,000 would qualify. So they're not blind, they're not disabled, they're not a pregnant woman. They're not 65 or older, therefore they don't fall into that category of the low-income elderly. They would qualify. How many people that is? That's an estimate that a lot of people have tried to clamp down. Anywhere from 220,000 to 300,000.
And so people understand the people now, and you can have a whole separate conversation about how people qualify to be permanently disabled. But if you were adjudged by the federal government to be permanently disabled, you've got Medicaid now. We're taking care of your health care.
Yes, as a matter of fact, if you have already been through the process of qualifying for supplemental Social Security benefits as a disabled person, you're automatically eligible for Medicaid.
So the population we're talking about has some income, but too much income to qualify for current Medicaid.
No, they don't qualify because they're not blind, disabled, or over 65 or pregnant.
Okay.
So the typical person, let's just say, is a worker that makes $18,000 a year. They make $18,000 a year. They're working for an employer. Let's say it's a small employer that's not mandated by the federal government to provide health insurance, and thus they don't.
Okay.
You're on your own. Just like the employer probably has, if they have health insurance, they're buying in the individual market, not the group market, meaning they're going to either the exchanges, if they qualify for subsidies, they could get those, or they're going to an insurance company saying, I just want an individual policy. And I'm not a group. I'm not bringing you my whole staff of employees here.
So is everybody in this population, would they all be working at least somewhat then? Or in a household where there's somebody working?
No, not necessarily. I mean, they literally could qualify if they have zero income.
Okay.
Under standard
they're
Medicaid
able-bodied.
expansion. But they're able-bodied and they could work.
Okay.
Okay. Theoretically, they could work if they're able-bodied. but they would qualify for Medicaid if they have zero income. I don't know how you live with zero income, but you would qualify. And so it's a little different. Now, what our lawmakers have suggested is to include a work requirements provision, meaning you got to work to qualify if we're going to expand Medicaid. You may, and you have to still earn less than 138% of the federal poverty level to qualify.
So if you're able-bodied and not working, you would not qualify under what's being currently discussed by the legislative leadership.
Technically speaking, and honestly, the definition of work requirements can get a little nuanced too. You could be doing community service, for example. You could be searching for a job. I mean, it gets a little complicated. But in general, the idea is, you're working.
And that's, you think about Medicaid, and I mean, this is true of all legislation, but it gets even more true when you start talking about Medicaid. These aren't the 4-page bills you saw at Boise State.
They're massive.
These are some real massive books you're looking at.
They're totally massive. So that's essentially who would qualify for Medicaid if the state expanded. The nuance to think about with respect to the work requirements provision is that 13 states have received work requirement waivers from the CMS. That's the federal organization that orchestrates and administers Medicaid and Medicare. 13 states received that during the Trump administration. Only one remains, and that's Georgia. A flurry of lawsuits were thrown at all these states, and they got tired of fighting them. Plus, the Biden administration immediately, when Joe Biden took office, said we're not issuing any more work requirement waivers for Medicaid. So I believe if the state of Mississippi submitted its proposal for a waiver for work requirements to expand Medicaid, I don't think the Biden administration would approve it. Now, we may have a new administration. They may see differently about that. The other thing I want to talk about with respect to the economics, in traditional Medicaid, where I said that we receive about 78% funding from the federal government, Medicaid expansion based on the Affordable Care Act, which is when it was even made available, this coverage group became eligible for Medicaid, the able-bodied adults, it's 90%. So the federal government permanently covers 90%. The state's responsible for 10%. There's another nuance to that, which is the American Rescue Plan, as an incentive, included a 5 percentage point uplift to the non-expanded states to expand on their traditional Medicaid. Another 5 percentage points on what they're currently getting on traditional Medicaid. So the state of Mississippi, and it's for 2 years. Yeah, it's for 2 years. It's about $700 million for 2 years. So when you kind of extend out the numbers over a 6-7 year time frame, the state really doesn't have a responsibility to cover its portion of Medicaid expansion until about 4 or 5 years out.
So the impact to the actual state of Mississippi budget from expansion is probably not that great, at least in the short term, because we're only paying a nickel for every dollar that gets spent.
Not exactly, because that additional 5 points is on the traditional.
Oh, it's on the traditional side.
That's the point, which is $6 billion. That's how we come up with the $700 billion additional from the Fed.
I'm with you.
So we're going to give you more on traditional if you'll expand under the expansion provisions of the Affordable Care Act, which is a much smaller population, because we have about 800,000 now on traditional Medicaid. So
can you stick with us for one more segment,
absolutely.
Gerard? Yeah. Y'all, this is Lucian Smith in for Paul Gallo here on the Gallo Radio Show on SuperTalk Mississippi. We'll have more with Gerard talking about health care and Medicaid expansion in Mississippi. If you've got questions or thoughts, hit us up at the C Spire text line at 601-879-4395. Stick with us.
That's cool.
Gerard, we've been talking about Medicaid expansion. One of the arguments that gets made is that Medicaid expansion is going to be a big economic boon to Mississippi because you're going to have, call it $1 billion of federal money coming in. And obviously, you and I are both aware federal money doesn't just magically appear. I mean, it comes out of your pocket and mine, and Mississippians are taxpayers too. But what do you think about the argument that there's going to be some sort of economic boost to the state of Mississippi if we expand Medicaid?
I guess it depends on how you define boost. That's subjective, and it depends on how many people sign up. And then, of course, how many new jobs does that drive? It's estimated to be 10,000 to 12,000, depending on whose forecast you look at there. But you can't. I don't think it's fair to say that $1.5 billion being injected into the state has zero economic impact. On the other hand, I don't know that it's time to break out the champagne either. I think it's somewhere in between. So there would certainly be some positive impact. At a minimum, all these hospitals that currently are absorbing so much uncompensated care, and there's no doubt, statistically, data proven that states which have expanded experience a much low percentage and dollar value as a value of their total health care work product when they expand Medicaid. There's no doubt about that because more people have insurance.
Yeah, more people having insurance means more people paying.
Now, the people who oppose Medicaid will tell you, well, Medicaid reimburses below cost. That's absolutely true. But it's better than zero. I think you have to look at it that way. So does it sort of stop the bleeding, no pun intended? Possibly. I mean, because right now, again, if they show up in the ER, they're going to get treated whether they can pay or not. That's just a fact. That's
so you're
going
to have more people who are covered, so you're going to stem some of it.
And the other thing, they would have access to primary care. They currently don't have access unless somebody just is willing to provide them some sort of primary care. And that's important because that's where you get all the screening that's used to detect something that could be coming down the pike health-wise. It's bad. I actually shared my personal story in 2006 when just in a routine physical examination, there was an occult blood test. It's an occult stool blood test, and a little blood was discovered in my stool, and that's a warning sign for a male. And so it was indicated to do a colonoscopy. Now, I was only 48. It doesn't run in my family. But my primary care physician says, well, we ought to just go ahead and do this. And I did, and 2 polyps were discovered. One was benign and one was cancerous, and I had surgery after that in the hospital about 6 days. It's brutal surgery back then. And I'm good. No other further treatment. Have only had one little bitty polyp in 18 years, I should say, since then. But what the GI told me is if we'd have waited 9 months to a year to find out about this, you may not be here today.
It goes, yeah, and that's one of the arguments for us. Presumably these beneficiaries would go get care. What has been the experience of the states around us that have expanded?
Yeah, and it depends on whose reports you read, right? If you want to paint it in a negative light, you'll say, oh, my gosh, people came out of the woodwork and signed up for this thing. Neighboring Louisiana is used as a base case for Mississippi in a lot of reports. And yes, it is true that the numbers exceeded the estimates. However, in Georgia, and that's one of the plans that the lieutenant governor's pointed to, far below the estimates. Fewer than 2,000 people have signed up in Georgia, and that is because they didn't fully expand. They only expanded it to cover the population up to 100% of the federal poverty level, not 138, and still have a work requirement. They have the only remaining lingering Trump-era work requirement, and fewer than 2,000 people. They estimated 500.
Well, this is an unfair question to ask you, Gerard, with about 30 seconds to the bumper, but what would you do in terms of health care in Mississippi?
Yeah, gather more information.
Okay.
I think in order for, and I'm saying this to both sides, honestly, Lucian, I have recommended to hospitals that say, man, if we just expanded Medicaid, it would just go a long way to helping our bottom line. Okay, that's reasonable, but if you've done a pro forma to show us, let's take the last 3 years' financial performance and insert Medicaid expansion into your financial statements. What would they look like?
What does that look like?
Right, to make that case. Otherwise, you're just kind of giving us those points without providing any supporting data. And I think the same could be said for the folks who oppose it. I think we need more data. How big is the population? Can we find out how many employers in the state, more than 50, provide coverage? How many below 50 provide coverage? And within that, what's the income level of those people? How likely are they? I can tell you this, as far as the ACA exchange in the state of Mississippi is concerned, there are 28,000 people who are eligible. 183,000 total, 28,000 that have an income that would make them eligible for Medicaid. And by federal law,
who are on the exchanges.
That's right. By federal law, if a state has expanded Medicaid, they shift them to Medicaid, and that's because it's cheaper for the taxpayer.
Gerard, thanks for being with us. Y'all, coming up next is Fox News, followed by SuperTalk Mississippi.